My name is Dr. Penelope Glenn, and I've been coordinating this series for about 6 or 7 years now. And this is one of the best panels we've got set up. So I have the distinct pleasure of introducing our moderator this evening. His name is Professor Ryan Andrews, and he's an assistant professor at Regis College in the Department of Health and Fitness Studies. He teaches 6 courses, 2 of which are nutrition along the health continuum and obesity and weight management, among many things that he does. Among the things he does do is he has done online nutrition exercise coaching and consulting for ryanandrews.com. He authored Swole Planet, a guide to planet-based eating, and Drop the Fat, Act and Live Lean. He's a member of the Vegetarian Nutrition Dietetic Practice Group and a member of the speakers at state dietetic conferences. He studied sustainable food systems at Columbia University in the executive education program, has just 300 plus hours of experience teaching trauma-sensitive yoga at Silver Hill Hospital, which is probably a good thing to be able to do. And he earned his RD at Johns Hopkins Medicine. I will turn the evening over now to Professor Andrews.
Penny, thank you. Wow, that was much more in-depth than I was expecting. You brought back a lot of memories. Thanks. So you are here, you made it. Good evening, everyone. Welcome to the President's Lecture Series. My name is Ryan Andrews. I'll be the moderator. RNs, social workers, faculty, undergraduate and graduate students from a variety of health professions, along with folks in the broader community, have registered for tonight's event. We are incredibly fortunate in having speakers who are prestigious, knowledgeable, and incredibly committed to their work. And importantly, they all seem to bring compassion to this topic of obesity. Like Penny mentioned, I teach a class at Regis about body weight, and on the first day, I always remind students that we need to start from a place of compassion, and we can always use this to reorient ourselves if things kind of get off track. A quote from one of our panelists, Dr. Anekwa, really captures what we're hoping for tonight. Obesity and its repercussions can be a very sensitive topic. We hope to open the door toward being able to discuss body weight and its implications in a respectful, candid, and most importantly, evidence-based manner. Before I introduce the panelists, I have a few items of business. Penny, would you like
to get to my slides?
Okay.
Just hold on
Excellent.
second.
Sounds good. Just making sure we're on the right track.
Yep. For some reason, I can't get my main picture off the screen, which is not a very good thing. So, slideshow, let me just get that from the beginning. All righty.
All right, a few quick reminders. First, to receive contact hours or class credit for attending this evening, you must stay until the end, which includes the Q&A period. For CEUs or class credit, you must click on the link to the evaluation survey that will be posted in the chat at the end of the Q&A. You must include your name, and students, you must also include the name of your faculty. And most importantly, you must complete the evaluation form and submit it. Here's what you can expect. So CEU certificates will be emailed to RNs in 7 to 10 business days. Students do not receive evidence of having attended. Your faculty will be sent a list of their students who attended. If you are not requesting contact hours or class credit, we hope you will still fill out an evaluation form, as we really do try to incorporate the feedback, and you will help us in selecting future topics. Again, the evaluation link will be posted in the chat at the end of the program. The link remains there until 8:45, so make sure you copy it, and the evaluation remains open until 11 p.m. A few additional reminders. You might have noticed that all attendees have been muted. We ask that you remain muted throughout with your video off. At any time during the program, you may submit questions directly to everyone in the chat. We will be doing things a little differently tonight, in that there might be some interaction between the speakers during the presentation, and we will allow time for a few questions after the first speaker. During the final Q&A session, we ask that you post your questions to everyone directly in the chat or to Tyler Feaster directly. During the last 10 minutes of the Q&A, you may also ask questions by raising your hand. If you are called on, don't forget to unmute. Okay, so before I use all of our time just for my announcements, the panelists and I need to get to know the audience a bit more, and then you will have a chance to get to know our speakers. So you should see a poll coming shortly.
I am going to try and do that. It has been so long since I have done this. Let me just go over. I'm screen sharing, and so let me stop that. And I do have my poll, if you'll just hang on a second. Across, let's just go here. It should have polls and quizzes. And here we are, and I'm going to launch it. Okay. Oh, wait. Okay, this is it. So if you can go ahead and answer these questions, I hope everyone can see the poll. Oh, another maybe 30 seconds just to answer it all. I think it's probably been about a year since I've administered one of these. This going into retirement is not easy. All right, I think, let's see, we have about 52%, 48%. Okay, I think I'll end the poll now. Okay, and I'll share the results. So here we are. Oh, gee, do you know someone with obesity? 97% of us do, and 3% of us don't. Have you tried to lose weight in the past? Oh, we have about 88% of us who have done that. Do you work with patients who are obese? Okay, so this tells us a little bit about the audience too, that we have 48% actually work with patients who are obese. And please note that I did not say obese patient because we don't label them. These are patients with obesity. And 4, would you say you've been successful in working with your patients? And we have 25% who say they're somewhat successful. Oh, 4% are really lucky. They do a good job. They're always successful. And 17% are rare. It's rarely successful. I suppose for those who are always successful, it depends on how we define success. And maybe most of us could have actually said that we were successful to some extent. But anyway, so that's who we are. And now we can go back and I will close this and we can go ahead and I'll make sure I stop. I'm not sharing my screen. Okay. All right, then. So I'll turn it back over to Professor Andrews.
Right, so I will get into some introductions. So I'll introduce all of the speakers. Our first speaker this evening is Corinne Homacheski, a PA at Newton Wellesley Hospital. Corinne is a graduate of Loyola University of Chicago, where she earned her undergraduate degree in psychology in 2013. She received, you're all set, Penny?
Oh, I'm really having a tough time here. If you just hang on one second,
right.
I'm gonna get, there she is. Oh, I went past her. There she is.
Beautiful. All right. She received her dual master's degrees in health informatics and physician assistant studies from Northeastern in 2022. Since graduating, she has been working at Newton Wellesley Hospital in bariatric and general surgery in both the inpatient and outpatient settings. She states, "I am passionate about providing education about the disease of obesity to aid in combating fat phobia within our society and medical communities." I recently started following Corinne on LinkedIn. Our second speaker is Dr. Chika Anekwa. Dr. Anekwa is an obesity medicine physician at Mass General Hospital and instructor of medicine at Harvard Medical School. She received her BA in molecular biology from Princeton University, her MD from the University of Connecticut School of Medicine, and her MPH from Columbia University. Dr. Anekwa completed her internship in pediatrics at NYU and a residency in general preventive medicine and public health at SUNY Stony Brook University Medical Center. She holds board certification from the American Board of Preventive Medicine, the American Board of Obesity Medicine, and the National Board of Physician Nutrition Specialists. Love that. Before joining MGH HMS in August 2018, she was a staff physician at Long Island Weight Loss Institute, the largest private obesity medicine practice in Long Island, New York. Dr. Inekwe's professional interests are in the areas of clinical nutrition, obesity, non-surgical weight management, health policy, and community health outreach, with a special interest in underserved communities. Bearing these interests in mind, she founded and is president of the New England Obesity Society, an organization that aims to provide education and resources for clinicians in the New England area interested in treating obesity and associated metabolic disease. Thus, her influence and education reaches far beyond her work at MGH. I recently started following Dr. Inekwe on X, formerly known as Twitter. She posted a really interesting pharmacotherapy and weight management article last month. Our next two speakers are Dr. Susan Himes and Colleen Johnson. Dr. Himes is a clinical research psychologist with dual appointments in the Department of Psychiatry and the Weight Center at Mass General Hospital, and is an instructor at Harvard Medical School. She received her PhD in clinical psychology with a specialization in eating disorders at the University of South Florida. She completed her internship at Temple Health Sciences Center and the Temple Center for Obesity Research and Education, followed by a clinical postdoc fellowship in health psychology, specializing in psychological and behavioral treatment for obesity and bariatric surgery at the Mayo Clinic. She completed a one-year NIH investigator-funded research fellowship at the Weight Control and Diabetes Research Center at the Miriam Hospital and Brown University, followed by a clinical staff psychologist position at the Rhode Island Hospital and Brown Medical School, where she became assistant clinical professor. Her research interests include the incorporation of treatments for mood and emotional dysregulation in behavioral weight management approaches, interventions to treat disordered eating, weight regain, and complications in the bariatric population, studying the relationship between binge eating and depression, and interventions to improve behavioral adherence and weight maintenance in bariatric patients. I haven't been able to track down Dr. Himes on social media yet. Hopefully I can connect with her there. Working on this presentation with Dr. Himes is Colleen Johnson. Colleen is a registered dietitian nutritionist, as well as a certified diabetes educator who is located in Boston. Colleen has a background in entrepreneurial nutrition practice and weight management, having achieved her MS in nutrition with a concentration in entrepreneurship from St. Elizabeth University. She works with young adults, and pregnant women at Joslin Diabetes Center in Boston. She is the co-creator of a diabetes remission pilot program and is a contract editor for Harvard Publications. Her background in weight management has enabled her to help many clients with medical, surgical, and lifestyle weight loss interventions. I recently started following Colleen on LinkedIn. And then our final speaker is Donna Smith-Williams, who will help us better understand the patient's experience. All right, and with all of that, I will turn it over to Corinne.
Great, thank you so much for the introduction. I'll go ahead and share my screen. Everyone see that okay?
Yep,
Okay, perfect.
we're good, we're good.
All right, so I just want to take the opportunity to thank everyone, Regis College, my fellow panelists, everyone involved in putting this event together. I'm really excited to talk about this important topic today. Before we get started, I have no disclosures. So some of the objectives I plan on talking about for this first portion of the talk today, we're going to define obesity. We'll talk about the incidence, prevalence, and impact of obesity, describe the disease of obesity. It's not a disease of willpower. And then we'll go ahead and discuss weight loss surgery. So what is obesity? We know that it's a lifelong, life-threatening, progressive disease of excess fat storage. We know that obesity is going to affect one's quality of life. It's going to make other medical conditions more complicated. It will kill people before their time. So we need to start thinking about obesity just like any other chronic disease. So if you wouldn't ignore a cancer, why would you ignore the treatment of obesity? So in the world of bariatrics, we talk a lot about BMIs and excess body weight. So it's important that we understand how these values are calculated. I'm sure A lot of you are aware of the BMI index, so it's weight in kilograms divided by height in meters squared. But then we also talk about excess body weight. So that's taking someone's actual weight and subtracting it from the ideal weight. So what is ideal weight? Well, there's this nice handy chart that was created by the Metropolitan Life Insurance Company table. So it's based on a BMI of 23. So this is used a lot to calculate, like I said before, the excess body weight. BMIs, there's 3 different classifications. So there's the ideal body weight that I just talked about, and then there's mild or class 1, moderate class 2, and severe class 3. And you can see the BMI ranges for each of these classifications. Now, I just want to be clear that BMIs are just a screening tool. It's not diagnostic of one's health of an individual. There's also a classification of obesity for children and adolescents. The CDC has a nice little quick calculator here for anyone that doesn't have access to it readily. And it's pretty much based off of the BMI for age growth charts. So that's why it talks about 95th percentile or greater, because it's basing it off of the growth chart. So let's dig in, let's talk about obesity a little bit. So we know that it's a major health problem, affects 25% of the industrial world. 74% of Americans are overweight, 42% of Americans have obesity, almost 20% of American children, so from ages 2 to 19, are overweight or obese. And it's almost 500,000 of deaths annually. So let's dig into these numbers a little bit more. So the next couple of slides, I'm going to show you the prevalence of obesity over the past 40 years. As far as these maps go, you can keep in mind the darker the color, the bigger percentage of that population with obesity. So this is 1985, 1990, 95, 2000, 2005, 2010, and then I'm going to go yearly from here. So 2011, 12, 13, 14, 15, 16, 17, 18, and you can see that the yellow is starting to fade away to more orange. 2019, 2020, 21, and then finally the most recent data we have is 2022. So as you can see, obesity is becoming more prevalent in the US over just the past 40 years. So high-level summary, there was not a single state that had less than 20% prevalence of obesity. 22 states had a prevalence of 30 to 35%, 19 had 35 to 40%, and 3 states had 40% or greater. And here's a prevalence summary by age. So we can see that the disease of obesity is becoming more and more common. And as healthcare professionals, we need to understand this disease and know what the treatment options are, which I will discuss in a couple of minutes. So we've established that obesity is common, but it's also serious. It's a serious health risk and it's costly. So for patients that have the disease of obesity, it's about $1,800 more of medical costs to them. It's also $173 billion a year in the US healthcare system. We know that it's prevalent, right? So 1 in 5 children have obesity, 1 in 3 adults struggle with obesity. We know that children with obesity are more likely to have obesity in their adulthood. And adults with obesity have a higher risk of developing heart disease, type 2 diabetes, and some types of cancer. Now, I highlight these 3 areas because they are among the leading causes of preventable premature death. Now, I said some types of cancers, but there's actually 13 that are associated with being overweight or obese. So obesity doesn't affect 1 or 2 cancers. That would be bad enough in itself, but it actually can affect 13. So this is even more of a reason of why we need to take this disease seriously. So what is obesity? Why is it that some have a disease metabolism while others do not? Well, as most things in medicine, there isn't just one thing that determines whether or not someone will suffer from the disease of obesity. But what we do know is that it's a complex multifactorial disease in which a person accumulates excess body fat. So some of these factors include genetics. So do you have a family history of obesity? Do you have insulin resistance? Some is behavioral. For example, like, was exercise important when growing up? Did you play sports? Do you cook for yourself? Do you mostly eat out? And then also environment. What kinds of food did your family have access to? Did you have access to healthcare? Did you have nutritional education? What was your socioeconomic status? So any solution to weight problems must address each of these issues. So I bring up this map now to highlight that as healthcare professionals, we need to keep in mind of someone's socioeconomic status, micro, macro aggressions, and healthcare disparities, because they all play a role in the increased prevalence of obesity in certain patient populations. So you see here on your left, non-Hispanic white adults compared to Hispanic adults, and you can see how much darker the map is for Hispanic adults. And if we continue that, these are non-Hispanic Black adults, and then non-Hispanic American Indian or Alaskan Native adults. So again, we need to keep this in mind when working with these patient populations. So why is it so hard to lose weight? So obesity is characterized by a dysregulated set point. So set point theory is a theory that we all have a set point that controls our metabolic adaptation to balancing energy intake and expenditure. So there's an active feedback mechanism linking adipose tissue or stored energy as intake and expenditure via a set point. Now, that set point somewhere along the way, due to our genetics, environment, stressors, have changed to create a different higher set point in our bodies, presumably linking some encoded somewhere in the brain, and this leads to the disease of obesity. So what can dysregulate a set point? Well, like I said before, it's multifactorial. These are just a couple of ones that I highlighted. For today's purposes and having something interesting to discuss, gut microbiome is starting to come out as new evidence that intestinal microbiome is intrinsically linked to overall health, including obesity risk. Mechanistic studies have indicated that GI microbiota can influence both sides of that energy balance equation I just previously discussed with you all, namely the factor in influencing energy utilization from the diet, and then the other factor influencing host genes that regulate energy expenditure and storage. So we've been talking a lot about this equation, the input and the output. Now we know everyone pretty much knows what the input is, but what are we talking about when we say expenditure? So total energy expenditure consists of three things. So one is the resting energy expenditure. That is how much calories are burned, how much energy is put into your daily activities, sleeping, getting up, walking around. Then there's also diet energy expenditure. So how much energy is burned chewing your food, metabolizing your food. And then finally, there's activity-induced energy expenditure. And this is the only one that's modifiable. However, this is usually not enough to tip the balance in starting to lose weight. So, quick little mental practice or problem for you all. What do you all think? I know that this is on Zoom, so you can maybe write it down, but what do you think the success rate is for treating obesity? So I did a BMI of 35 or above with diet and exercise alone. What percentage do you think people can keep off their excess weight with diet or exercise alone? So 1%. I bet that is probably a very surprising number for you. And then what about a BMI of 40 or above? About 1 in 2,000. So I hope this is starting to solidify in everyone's mind that obesity is not a character flaw. It is not because someone is lazy or has a willpower issue. It is truly a metabolic disease. So I thought this diagram was nice to show the impact of obesity. You know, it's important to remember that it's not just a number on the scale. Obesity is life-threatening, and it affects multiple organs and systems, endocrine, cardiovascular, not to mention the psychological impacts of having obesity. So a lot of the quality of life is affected. You know, 73% If patients are unable to cut their toenails or cross their thighs comfortably, they don't feel comfortable in dressing in front of their spouse, or they have to sleep in a different room because they snore so loudly. So we also have to keep that in mind as well. So knowing that exercise and diet alone is not enough, there's got to be a better way to treat obesity, and one of which is bariatric surgery. So the American Society of Metabolic and Bariatric Surgery has a nice little overview here. So they say it's the most effective and long-lasting treatment for severe obesity, resulting in significant weight loss and the improvement, prevention, or resolution of many related diseases. It also shows that studies have shown that it will reduce a patient's risk of premature death by 30 to 50%. Bariatric surgery is also very safe, or safer than the most commonly performed surgeries in America, and that includes gallbladder surgery, appendectomies, and knee replacements. It's also very effective. So on average, patients maintain 50% of their excess weight after 5 years. And then if you see below here, look at the non-scale victories, right? Look at the remission rates of all of these conditions and diseases. 92% of patients that have bariatric or metabolic surgery have their diabetes in remission. This isn't even just improvement rates. These are remission rates. 75% hypertension, 96% for sleep apnea, 58% for cardiovascular disease. So it's not just about the number on the scale, it's about the health benefits that happen afterwards. Now, I talked about the quality of life, because non-scale victories and the quality of life are really important, right? We don't just treat the disease, we're also trying to treat the person and help them have a happy, healthy rest of their life. So this study showed, so it has the 2 lines are for patients that were either going to have sleeve or bypass surgery. And you can see that this was their quality of life, that they got a questionnaire, and this was their quality of life to those answers before surgery. And then look how much it improved after surgery. So like I said before, bariatric surgery is safe. The risk of death is 0.1%. And it's also cost effective. Third-party payers will recover their costs within 2 to 4 years. So we like to say that surgery is the undiet, and this is why. So you can see in this line here that diet's going to increase your appetite, your hunger, reward-based eating, your stress response. It's going to decrease your satiety and your energy expenditure, while surgery does the exact opposite. So it makes you less hungry, more satiated, less reward-based eating. You have a greater energy expenditure than the input, and a decreased stress response. So weight loss surgery has been around for a while now, being officially accepted as a treatment for obesity in 1991. However, that was 33 years ago. So they came out with new updates in 2022 that anyone with a BMI of 35 or above, regardless of any comorbidities, bariatric surgery is recommended. They also adjusted the BMI for Asian populations down to 25 BMI. And they still say like long-term results from metabolic surgery consistently demonstrate safety and efficacy. Now, the problem is that insurance companies haven't yet adopted the ASMBS new recommendations. And so currently in the bariatric worlds, this is what insurance dictates on if a person qualifies. So a person with a BMI of 40 or above, they qualify for surgery. For people with a BMI of 35 to 39.99, depending on the insurance company, they either need 1 or 2 obesity-related comorbidities. So that's type 2 diabetes, sleep apnea, hypertension, those sort of things. And then, of course, there's also patient selection criteria, which I will talk about in a minute. So those that don't qualify are those in the range of 35 to 39.9 that don't have any comorbidities, even though ASMBS recommends that they should qualify. And then anyone with a BMI of 34.99 or less with or without comorbidities would not qualify for surgery. So a little bit more about patient selection criteria. Like I said, we're not just treating the disease, we are also helping treat the person. So they need to be focused on improving their health. It's not just about the weight and the number. They need to be mentally stable. So not that having a mental illness history precludes anyone. We just don't want anyone to be like actively manic or depressed. We just want them to be stable and fully aware of what they're getting themselves into. And not be active users. So again, patients need to understand the rationale, the risks, the benefits, the fact that they need to have lifelong follow-up and take vitamin supplements regularly. And they also need to assume some responsibility for the results and motivation. And because we say that surgery is just a tool, surgery alone is not enough. So it also needs to focus on dietary and lifestyle changes, like I've kind of listed here. And be aware of the risks and the benefits. Some of the risks is addiction transfer, smoking, alcohol, shopping. They need to know that they have to take vitamins, that they need to focus on their nutrition, they need to exercise. And most bariatric programs do a lot of education before a patient gets surgery. So now let's talk about bariatric surgery. So before we get started, I just want to review everyone on the normal anatomy. So we have our esophagus here with the stomach, pylorus, the liver and the gallbladder are very closely related, with the liver kind of overlaying the stomach a little bit. And then of course that leads to the small intestine to then lead into the large intestine. So for the sake of time, I'll just focus on the risks and benefits of each surgical option and not so much the technique of how it's performed. So to the left here is the sleeve. So essentially we staple the stomach up and we take about 80% of the stomach out. And that is the restriction part of it, because we like to say we're turning your stomach into sort of a banana shape sleeve. So that's the restriction part. The metabolic change is all of this that we remove. Now you have like decreased ghrelin, increased leptin, and that sort of the metabolic changes is when I talked about the increase of energy expenditure. There's no intestinal bypass, and there's few nutritional issues with this procedure. And patients usually on average have about 50 to 70% of their excess weight lost. Now for a bypass, there's restriction, malabsorption, and metabolic change. So the restriction part is this here. So we turn the stomach into a pouch, about like walnut sized, and we take the intestine up and sort of bypass all of this. So as you can see here, the arrow shows the food, comes down the esophagus, goes down the alimentary route limb, and then eventually meets up. We call this the biliopancreatic limb, because this is where the bile and the pancreatic juices will come down to eventually meet the food. So the metabolic change happens here, and then the malabsorption part is all of this intestine that we're bypassing. Now, because we're rearranging intestine, there is the risk of internal hernia because you're creating a space. Now we do close that during surgery, but with weight loss, spaces can open, things can loosen, so there's that risk. You also have to avoid certain medications like ibuprofen, Motrin, Aleve, NSAIDs, because the intestine that we connect to the stomach here is not used to seeing direct stomach acid. So it's already at higher risk. So patients really need to avoid NSAIDs, smoking, steroids, anything that increases the risk of ulceration. And it also has very similar weight loss results. About 60 to 80% of the excess weight is lost with the bypass. Finally,
Corinne, this is wonderful. We have about 1 minute remaining.
Perfect. Okay, I'll go
great,
super quick.
Great.
And everyone has the slides anyways, right?
They should be posted, yes.
Perfect. Awesome. So then there's also the DS that is happens after the sleeve, which is about 80% excess weight loss. It's usually done as 2 steps, sleeve and then the DS. Bands rarely performed now in the US for all of these risks listed here. It's restriction only and there's no metabolic change. So you don't get a lot of the health benefits, which is the goal of surgery. We do a laparoscopic and robotic laparoscopic approach. Those are the 2 most common approaches now in the US. And then numbers wise, so who gets what? The most common procedure is the sleeve, about 60%. The next common is bypass surgery. However, only 1% of people who qualify after actually get surgery in any given year. So I think this talk is really great because we can educate healthcare professionals to let their patients know what treatment options they have. Again, this is just a trend showing that sleeve gastrectomy is more common, getting more and more common for the risks and benefits I stated earlier. And this is a nice little summary of the comorbidity reductions after bariatric surgery. And again, you can see a lot of this is resolved or remission, not just improvement. So key takeaways, obesity is a multifactorial disease. It's a dysregulation of one set point. We know obesity is serious, widespread, and prevalent. And then that bariatric surgery is one of the most effective treatments for obesity. Again, I just highlighted some mortality reduction here. But now other treatment options also exist. So with that being said, and in case anyone has any questions, I'll now give it away to Dr. Chika Nekwe, who will further discuss some of the other options we as healthcare professionals can offer our patients.
Thank you, Corinne.
Yeah, of course.
So the slides are loading up now, but I'll be talking more about just overviewing obesity, recapping what we've just learned, and then talking about some of the non-surgical treatment approaches. So we can maximize the slides and I'll jump right in. So the next slide, please. Next slide, please. All right, wonderful. So just to recap some of what we learned already about obesity definitions. So we know that BMI is one of the main ways that we still assess and kind of quote unquote define obesity by the numeric standards. So body mass index greater than or equal to 30, and that's calculated just quickly and easily from a person's height and weight. So height in kilograms divided by weight in meters squared. So this is clearly a really easy way to calculate this metric. It's easily accessible in any primary care office or specialty office. Even at home, we can easily calculate this. And that's why we still use it very frequently. But as Corinne did state, it's meant now to be approached more as a screening tool. And the reason for that is because this numeric definition doesn't really tell us anything about the underlying causes or the consequences really of that elevated number on the BMI. And the BMI number also doesn't take into account any of the body composition or the excess fat that's actually the cause of the metabolic dysregulation that we see in people who have obesity. So we're moving more towards defining obesity, not just by this numerical number, but by the actual consequences and abnormal dysregulation that we see that poses an actual risk to health with people who have excess body fat and obesity. And so last year, the AMA did actually put out a statement which really encourages healthcare providers to move away from using the BMI alone as a clinical measure or clinical metric when we're discussing, evaluating, and treating obesity. Next slide, please. So I wanted to go over a little bit of the history of the BMI, which Corinne did touch upon a bit in her talk as well. But if we go back to the 1800s, we understand that the BMI was first developed as a metric that looked at measuring the degree of obesity in the general population. So it was never intended really to be used as an individual metric for assessing health risk on a one-on-one situation. And when the data for the BMI was collated and put together, it was based off of measurements, body weight and size and height and weight measurements from a specific population, which consisted mostly of French and Scottish male participants. And so you can see, obviously, from that demographic, it's really specific to this group of people. Moving into the early 20th century, more and more you saw people having scales in their home setting, and people were able to use height and weight metrics to start to look at what correlated with decreased life expectancy. And then, as Corinne noted in her slides, the Metropolitan Life Insurance Company then started taking these measurements and these metrics into the mid and late 1900s and using them to create tables, which they classified as ideal body weight tables, and then moving into desirable body weight tables, and then finally just simply height to weight tables, which is what we kind of have gotten used to seeing when we go into primary care settings or office settings, those BMI charts that are plastered over the walls. And so the physicians and other healthcare providers then started to use these quote unquote ideal weight tables for their own clinical assessments in the office. And then this is where we start to see the problematic nature of it, because it was a metric that we used for populations that's now being applied in the clinical setting for one-on-one patient visits. So moving to the next slide, we can kind of start to understand why it's problematic. And that's because the BMI misses a lot of things. As we said, it's just height and weight. It doesn't take into account body fat percentage or body composition. So your body composition takes into account the different components of our body. So we have a certain percentage of water in our bodies, about 50% water. And then we have bone, we have muscle, and we have our organs and other lean tissue. So when we talk about obesity, the problematic part of the body composition is the excess fat. All the other parts are not problematic at all. So when we're talking about weight and weight loss and weight gain, it's the changes in body fat that we're worried about when we're discussing obesity, not the other parts. And in fact, we actually want to increase, if we can, body water, not to the point that we're retaining water, but just having a higher percentage of body water and not being dehydrated, for example. And we want to increase lean mass because that's our muscle and that's our organ and bones. Those are things that are helping us keep healthy and have positive contributions to our composition. So what also the BMI misses are the weight-related health conditions, many of which we've discussed and have just reviewed. So, and some of these are, kind of the weight of the fat itself, the fat mass causes problems in terms of joints issues and, compressing on the the pulmonary system and cardiovascular system, so that can cause issues. And then also the actual metabolic concerns that arise when you have dysregulation in your blood sugar regulation and hormonal regulation, things that are all affected by excess body fat. Also, I didn't mention inflammatory issues that can occur with excess body fat. And then we also start to see the impact of the excess weight on quality of life. So some of the non-weight things that Corinne also pointed out to us were things such as diminished mobility or chronic pain that can be affected with the excess weight, diminished energy levels, and then the impact in terms of a mental health standpoint for psychosocial wellness and self-esteem issues that can arise with excess body weight. Next slide, please. And so as just to underscore this point once more, the BMI often is inaccurate in determining an individual's health for all these reasons that we've discussed. There are actually metrics now for certain populations where we're starting to understand that BMI is really not, should really not be applied on a scale, population scale measure, because in certain populations, there is evidence and data for different risk factors starting at different BMI cut points. So we do have data from the WHO and official recommendations leaning and recommending that we start to underscore or start to assess and evaluate risk for Asian populations at lower BMI cut points. Versus for people of African ancestry, we should be looking at higher BMI cut points before we start to look at risk. And even that last section there, there's even evolving data that for certain demographics within the African ancestry still have even cut points that are lower that are needed to start to assess metabolic risk. And so again, underscoring, we're kind of talking about population metrics here again, but just knowing the bottom line should be that when we're looking at a person in office or in clinic on a one-on-one setting, this is an individual that we're looking at. And so we're going to be looking at their specific metrics, their specific comorbidities or other weight-related health concerns when we're evaluating and treating them. And the BMI and other population measures should be used as just a screening or guiding tool. Next slide, please. All right, so this slide is adapted from a presentation from one of my colleagues at the Weight Center, Dr. Fatima Cody Stanford. Some of you may or may not have seen her when she was featured on the Oprah Daily interview a couple months back, and this was one of the slides that she used. So I really wanted to emphasize it and highlight it because I think it does a great job of explaining why we can start to understand and conceptualize obesity as a disease. So so we have the image here of the brain, and there's two different pathways that regulate our body weight. The anorexigenic pathway, which stems from the Greek word anorexia, which means basically a decrease in hunger, a decrease in appetite. And this pathway affects not only our food intake, so leads to less food intake because we're less hungry, but can also lead to less fat storage. And so people who are kind of operating more so on this anorexigenic pathway may have a decreased food intake, but even the food that they take in may not be stored as fat as much as it would be in somebody who's not operating on that same pathway. The opposite pathway is the orexigenic pathway. So this is a pathway that increases food intake, increases appetite, and also leads to more adipose storage. So obviously on this side of the pathway, we're looking at people who have higher hunger hormones and hunger signal, higher appetite, and also the food that they're eating is more easily stored as fat. So clearly, different pathways are going to be up or down regulated depending on the individual and can affect how or their propensity towards obesity as a disease. Moving on to the next slide, we're going to start to turn over and talk more about treatment options. So this diagram here shows our treatment option kind of pyramid in a pyramid schematic. So at the bottom of our pyramid is kind of our base of our pyramid is our foundation. These are the things that are encompassing encompassing lifestyle and behavior. So our kind of like lifestyle habits are what underscores just overall health, regardless of whether you have obesity or not. This is going to include things like dietary focus, physical activity, stress management, and sleep. So these are things that we need to be optimizing regardless of our body weight in order to maintain our health and wellness. As we move up along the pyramid, we start to see that there's more intense treatment approaches and behavior interventions that can be applied depending on a person's status. So with higher BMI, higher obesity, higher dysregulation, we can then start to see more intense treatments need to be thought of and applied to the patient. So the next level up on the pyramid is intensive medical intervention. And by that means basically focusing on more specific dietary strategies or programs and more intense dietary strategies and programs. This could include like more specific regimens such as meal replacement programs, more specific dietary guidance, which will include help from our assistance from our dietitian colleagues and our psychology colleagues as well that can help to implement these programs and help a patient sustain these behavior lifestyle programs. Next level up on the pyramid is where medications or pharmacotherapy come into play. And this is where specialists in my area are going to be focusing and working with patients to treat obesity with pharmacotherapy. And we did discuss the surgical part prior, so I'm not going to review that in too much detail. But you can see here on the slide the different BMI cut points at which a person may meet qualifications for receiving these other more intense treatment options. So as I stated, we'll be delving into the pharmacotherapy during my section of the presentation. So we can move on next to the next slide. And I did want to just briefly review some of the non-prescription treatments before I go into pharmacotherapy. So you can see here weight loss programs is kind of just used as a general term here to describe different types of programs that can be implemented, not using medicine, but using more behavior lifestyle approaches. So we're going to talk a bit in a couple upcoming slides about different dietary approaches, but a lot of the diets, quote unquote diet, even that word itself can be a loaded term. Because when we talk about diets in the obesity treatment world, we're not talking about these fad diets that you may hear or see of, or hear about or see in the press or social media, for example. These would be things that are very specific interventions, like here I just listed keto diet, go low, IF stands for intermittent fasting. So when we talk about dietary interventions, we don't want them to be a fad. We want them to be a change in the lifestyle that can be sustained and applied for the long term. And so that's different from, I think, what the popular press might put out there, what you might hear colloquially as when somebody's saying that they're on a new diet or something for the new year, for example. That's not what we're doing when we're treating obesity. We want these to be long-term sustainable changes. And very similarly for physical activity, we're not talking about intense programs that you burn out on and you can't sustain. When we're treating obesity, we want anything that we're applying as a treatment approach to be long-term sustainable and a new implemented tool that the patient's going to be doing in a long-term fashion. Moving on to the next slide. I wanted to touch a bit upon different behavioral programs that you may have heard about or see out in media and just out and about in your day. So Noom is very popular. This one is an artificial intelligence guided program that uses also cognitive behavioral therapy approaches and evidence-based treatment principles in physiology and psychology to help people improve their eating behaviors. So many people are familiar with this app. It's a program that's really well known, and I think one that's really successful in helping people to adopt changes in behavior and lifestyle for a long-term basis, or at least as long as they're able to continue the app and the protocols from the app. WW, also known as Weight Watchers, is also very well known. So I just wanted to highlight that. Everyone, I think most of the people are familiar with the point system that's implemented by Weight Watchers. So again, a way of kind of helping the person to understand and be engaged in what their eating behaviors are and really mindful of them, and kind of using that point system as a guide towards affecting and long-term changes in the dietary intake. Optavia is a meal replacement program that also includes some community and health coaching components. It's mostly going to be a low-calorie intake with the use of the Optavia branded foods. And I just wanted to say as an aside, I'm not consulting for or involved in any of these programs. These are meant to be used as just examples to demonstrate the concepts here. I'm not promoting or enforcing that these should be used in any particular setting. And then Eat Right Now is a very similar program using mindfulness-based training to help rewire the brain and really help people identify what are some of the emotional triggers to help them recognize what's triggering their emotional or stress eating, recognize when they're having cravings, and help to stop the behaviors from propagating and implementing and moving them towards a unhealthy eating program. And then finally, employer-based programs are becoming more and more prevalent, which basically help people to be more accountable for their dietary and behavioral lifestyle choices. And they're often sponsored and funded by the employers as a way, kind of like a population-based method of helping to reduce health concerns in that employer-based setting. Next slide, please. So we're going to go now, and you can advance again, into the different prescription medication options. So on the next slide, we can then start to look at this list of what are the FDA approved and FDA non-approved or off-label treatments that we use for treating obesity. So I won't spend too much time on going into like specific pharmacotherapy, but I did want people to just have this list of different options that are available. So on the FDA approved column, we see that there's the stimulant medications. So that's the phentermine, phendimetrazine, and kind of sister medications. Some of these are on the older side. They're not used as commonly. Orlistat is a very old one. That's a fat blocker medication that I would say we're moving away from quite significantly because of the GI side effects. Setmelanotide is approved medication for treating specific genetic causes of obesity. So it's often used in the pediatric population, but it can be used in adults as well. And then on the lower side of that list, we have phentermine topiramate, naltrexone, bupropion. So these are both combination medications that go under the respective brand names Qsymia and Contrave. And then finally, kind of like the newer blockbuster GLP-1s, which is what we're hearing about more and more often in the media as of late. So Saxenda is the first one that was FDA approved for treating obesity back in 2014, followed by, and that's liraglutide, the generic liraglutide, followed by semaglutide, which was initially approved for diabetes under the brand name Ozempic. So that's on the off-label column because that's specifically for diabetes. And then Wegovy was the brand that was then approved for treating obesity. And then most recently was tirzepatide, which is actually a dual hormone agonist medication. So it's GLP and GIP. I'm going to go to those acronyms in the next slide, but Zepbound was the newest approval as of November of 2023. If you advance the slide, we have some upcoming pipeline pharmacotherapy. If you hit the next slide, Penny, please. There we go. In the pipeline, GLP-1 and GIP and glucagon triple agonist medications are in production now, in clinical trials now. And this is the next kind of what we anticipate to be the next big blockbuster, going now by the generic name retatrutide. And we'll see in the future what they end up branding that out as when it's released. So going on to the next slide, I wanted to talk a little bit just about some of the effects of these medications. I'm focusing now on GLP-1 as like the single hormone agonist medication, but just keep in our back of our minds that the dual hormone GLP-GIP, which is tirzepatide, as well as the pipeline triple agonist, retatrutide, is going to have similar effects because the other hormones kind of work in synergy with GLP-1 to kind of augment the effects. So GLP-1 is a hormone that helps us to feel fuller and more satiety with our food intake. So one of its primary mechanisms is that it delays gastric emptying and decreases GI motility. So the food that that's coming into our stomachs is emptying out at a slower rate, which helps us feel more full. This hormone also has effects on increasing insulin and helps your body respond to the food intake that you're having. So the insulin is secreted in response to having sugar in your GI system. And then the antagonist hormone glucagon is decreased. This all has the effects of reducing our blood sugars, not to the point that we're getting hypoglycemic, but more so the way I describe it is that it stabilizes blood sugars. And that's why these medications are often dually FDA approved for treating diabetes as well. And so the ultimate outcome is that you have a decrease in appetite, a decreased food intake, and sometimes also decreased water intake. Some people do report that they have less thirst signals, and so they have to be consciously mindful of maintaining adequate hydration. If you move to the next slide, I wanted to just show some of these like major headlines that have been out, and this is really just a snippet. Literally, you could probably see a new article every day about these different medications, whether it's Ozempic, Mounjaro, Wegovy, Zepbound's now, and now the new pipeline ones that are getting previewed in the media now as kind of like new up and coming agents. But I know for a fact many of the people, if not everybody in the audience here, has heard of these medications and knows that there's a big, like just attention and kind of rush of attention really on these different medications. And I wanted to talk about them in a more like realistic way. So if you move to the next slide, I wanted to underscore that we really are in this, what I call the age of semaglutide. If you kind of like think about the history of obesity and the history of weight management, and even I think in our personal experiences, we've seen magazine covers over the years, over the decades, they're always shifting for like the newest diet, the newest fad, what's Oprah doing? What are the celebrities doing? How are people losing weight? And that's, I think, all things that we have focused on in the past in terms of understanding and conceptualizing obesity as something that you can just deal with the diet or do with a new fitness plan. Now, the current, I think, arena is that we're starting to understand how these medications work and how they really affect the physiology and affect the metabolism of the individual who's taking them. And we're starting to see that it's not really going to be just diet, just exercise alone. That's a component, certainly. But there's physiologic and metabolic changes that are at play when we're talking about obesity. And these are things that are sometimes really helped and improved by the medications. If you go to the next slide, I just did want to underscore, though, that the kind of like the contrary, which is that these medications are in and of themselves not a cure. So yes, we are treating obesity when we offer these and prescribe these meds, but we do still need to emphasize the underlying behavior, lifestyle, making sure there's an adequate intake of nutrition, adequate protein, balanced dietary intake, physical activity, stress relief, and stress management, and that all the other lifestyle components are being addressed. And then on the following slide, I wanted to review some of these pros and cons. So I think oftentimes physicians and healthcare providers are accused maybe of emphasizing and trying to sell things to people. Again, I'm not being endorsed. I'm not supported financially in any way by any of these pharmacotherapy or pharmaceutical companies. So I did want to present this balance here and looking at both the pros and the cons of these medications. So what we know is that they are safe, they're effective. I think one big pro is that they are dosed weekly, at least some of the newer agents like the semaglutide and the tirzepatide. And we do have clinical trial data that does show demonstrated decrease in morbidity and mortality, which has really been borne out in the studies showing that there's a 20%, when talking about semaglutide 2.4, aka Wegovy, their data was the most recent to come out. This was one of the cardiovascular outcomes trials that showed a 20% reduction in both fatal and non-fatal heart attacks and strokes for people who were taking that particular injection over a 5-year follow-up period. So we do have going on half a decade's worth of data on these meds. And if you include the data from just the ones that were approved for diabetes, that goes back, much longer than just a decade. So we do have growing evidence that these medicines are safe and effective. Cons now, on the other side of that coin, is that there are side effects that can be experienced with any other medical treatment. I'm going to come back to that in the next slide, but another con potentially is that these are injections. So some people do need to kind of get used to the thought that they're giving themselves an injection on a weekly basis when they're on these medications. And in the middle of our chart here, I did want to put this concept that these meds are meant to be used long-term. So I didn't know whether to put it as a pro or a con, quite frankly, because I think depending on how you look at it, it can be one or the other. For somebody who's struggled with obesity their whole life, I think it's a great thing that these meds are meant to be used long-term, because the minute you withdraw your treatment, you're going to see that the medical problem is going to resume. So you want something that's long-term if you're going to have long-term results with it. That being said, I do understand that medicines are something that we're putting into our body, and a lot of people don't wish to be on a medication long-term if they don't have to be. And I think the important thing to understand is that oftentimes that is the case, that without the treatment, the disease process does recur. And so the long-term use typically is necessary to see long-term remission of the obesity state. So moving on to the next slide, please. I wanted to just, again, underscore some of the potential side effects that are seen with these medications. So the most common one is gastrointestinal. So these GLP-1, GIP medications are known to cause nausea. And if it is a severe reaction, can also be associated with vomiting. Sometimes it's constipation versus diarrhea as a potential complication. So people are well aware of these. We always discuss these potential risks and side effects going in. On the more concerning side, and things that I think that are highlighted often in the media as maybe cause for alarm, is that because of the delayed gastric emptying, you can see some cases of intestinal obstruction. So this is not something that just happens overnight. Often you'll see the severe constipation building up and then leading to abdominal pain, bloating, and then loss of bowel movements, loss of gas release. And then obviously you're seeing that that's a serious situation. So we always advise patients on what to look out for if this is going to be something that's happening to them, so that they could reach out well in advance and get medical care if needed. Similarly, for those undergoing anesthesia, aspiration is a potential concern. So we do advise stopping these injection medications. At least at MGH, we would advise at least about 2 weeks off of the meds before going under anesthesia. And then there are the black box warnings looking at risk for medullary thyroid cancer and pancreatitis. And to underscore this medullary thyroid concern, that risk is something that was seen in rodent studies, and it's not something that has actually borne out in the human population. So if there's a known family history of this, we do avoid typically to prescribe the medication. But aside from that, there haven't been any surveillance studies showing an actual increased risk of this type of cancer in people taking the GLP-1 medications. And then finally, something that, again, has gained more attention recently is the potential effects on mood and emotional well-being. So this is something that's currently under investigation, both in the European Union and by the FDA more recently launched their investigation. Most of the data seen here is on case reports, or people report or clinicians report patient cases of decreased mood or increased suicidal ideation or suicidal thoughts. But again, these are case highlights. Nothing has been seen on a population level that has indicated a strong signal that these medications are the cause of these changes in mood. So we take this as a case-by-case basis when we're seeing patients, and understanding that there can be contributing factors with weight loss that can affect a person's mood, or other factors just in their general life that could be co-occurring with the onset of starting the medication. So we obviously monitor very closely. Next slide, please. I just wanted to just briefly show the metabolic and bariatric surgery images again, just to review what we've already learned about the different types of procedures that are done, and just emphasize the fact that bariatric surgery certainly is still part of the treatment toolbox. And as we've already learned, it is the most effective treatment for getting off a significant amount of weight for the long term and keeping that weight off long term. But that being said, it does play a role alongside the other tools that I've been discussing with the long-term maintenance of weight status. And so we do use all these tools in our toolbox still, and we use them appropriately as indicated, depending on the individual patient, their insurance status, and their wishes and their personal needs and desires. Okay, so next slide, I just did want to highlight that we're going to be having a short talk from one of my patients, Donna, who's here on the Zoom, I think, with us tonight. So this is some of her background information, which I'm sure she'll be reviewing with us as well. But she is somebody who has undergone the gastric bypass. That was back in 2008. And these are some of her metrics. Her pre-op weight was about 320 pounds. She did reach a nadir weight, or her lowest weight was 165 pounds. And then due to some weight regain, we did end up needing to restart her on some of these anti-obesity medications. So she'll be telling us more about her journey in the upcoming presentation. But to move along, we can move on to the next slide.
Dr. Nicholas, sorry to cut you off. If you could wrap in the next minute or so, that would be amazing.
Absolutely.
Thank
Yeah,
you.
no problem. Thank you for the reminder. So
Thank you.
obesity health, I did want to just kind of put this in a bigger contextual picture. This is a public health challenge and really a crisis. So right now it's a crisis on different levels because we have people who we know meet criteria for treatment. As we discussed before, people are not getting the treatment they need, whether it's surgery or medications. And even behavioral lifestyle opportunities are being missed because of the immense burden on the healthcare system due to the number of people that are affected by obesity. So right now, who's paying? Honestly, I think society is paying because we have all these people who are in need of treatment, are not able to afford it, or are not insured or underinsured, are not able to access their treatment. This is compounded by the drug shortage problem, which many people here probably have been familiar with, just the lack of supply of many of these medications, whether it's for obesity or for other medical issues as well. We're seeing that across the board. And so we have this kind of preventive medicine, public health outlook where we need to start to understand and strategize ways for handling obesity on a population level, because this problem, as we've seen from those diagrams that Corinne shared, is only getting worse over time. We don't have any indication of any improvement. All right, 3 more slides left. So next slide, this is just a highlight of something that I came across when I was watching the Oscars the other night. I don't know if anybody else here is a fan of like pop culture and celebrity culture, but these are 2 ads that were run by the Eli Lilly pharmaceutical company highlighting weight stigma. So this ad on the left was talking about the experience of somebody with obesity and the shame that's experienced often with obesity. And we're going to be hearing more about that in the talks by our colleagues coming up next. And then finally, also a kind of like highlight on the drug shortage problem, that it really matters who gets these medications. They shouldn't be used indiscriminately by those who just need to lose, 5-10 pounds to fit into a nice dress. These are used for treating obesity for people who are really suffering and struggling with a serious metabolic disorder. Next slide, please, is just a highlight of a study that I'm running here at the Mass General Hospital, looking at the use of meal replacements. Our program at the MGH Weight Center called MINT, which stands for Medically Intensive Nutrition Therapy Program. Currently, it's only available for those who pay out of pocket. And so I did launch this research study with funding from the Nutrition Obesity Research Center at Harvard to be able to enroll patients who have both obesity and overweight with a BMI 27 or greater and have a low income. So we're using study funds to cover the cost of the program for them. If you or any of your patients are interested, please feel free to scan that QR code there to learn more, or call the number there, or email me if you're interested in hearing more about that study. And then finally, on the last slide, if you advance, I did want to offer some resources and information about how you can learn more. So different CME courses and courses run through Harvard and the Boston Obesity course. All the QR codes are here if you wanted to scan and learn more. The Obesity Medicine Association, the Obesity Society, and my organization, the New England Obesity Society, all have further opportunities for learning and engagement in treating obesity. So with that, I'm going to turn it on over to Colleen Johnson, who's here on the line, to talk more about weight bias, weight stigma, and the rest of her slides will be coming up shortly. Thank you so much.
Great, thank you so much, Chika, and thank you, Regis, for having me. I'm so excited to be participating today. So my name is Colleen Johnson. I am both a dietitian and a diabetes educator. My background is in weight management. I have worked in bariatric settings before, medical weight loss settings. Now, more recently, I'm working in diabetes. So I work with young adult populations, adult and women in pregnancy. Next slide. So weight bias, the definition is the negative attitudes, beliefs, judgments, stereotypes, and discriminatory acts aimed at individuals simply because of their weight. It's important to recognize that for the people here working in health profession, as professionals, it's important that each of us evaluate our own biases and our own judgments about other people, especially when you're new into the field or getting into the field, because it often comes out in very subtle ways and it can cause long-term lasting effects on our patient population. Next slide. So weight bias itself often includes prejudice, stereotypes, discrimination. It can be really subtle. People can assume certain things about someone, oftentimes assuming that someone has a lack of willpower, that they're not trying hard enough, that they could do this if they really wanted to, that sort of thing. And so it can be really subtle. Sometimes it can be really direct or aggressive. So there's microaggressions and then there's straightforward aggression. And that inability to lose weight, which we've seen from the previous educators, is that, this notion that if people really wanted to, they could. But the reality is that it's very difficult to lose weight, and it's difficult to sustain it with just lifestyle or dietary interventions. There are organizations now that are keeping track of people who have been able to lose weight successfully and how they did it. But again, it's very, very difficult, and it's not in the norm. Next slide. So who can be affected by this type of bias? Really, anybody can. People of any size can experience weight bias or stigma or experience its negative effects. So it doesn't just affect the individual, it can affect those around them, it can affect their families, it can affect their friends. So stigma is more common though among people with diabetes. So working in the diabetes world now, it's been very eye-opening seeing how often people are dealing with this on a day-to-day basis. People with type 2 diabetes experience stigma at a higher rate. So the rate is 53% compared to 19 to 41% in the general population. And that's just an estimate. I would suspect it's probably even higher than that. Next slide. Why it's important. A lot of times if people are afraid that they are going to experience stigma, they might not seek medical care for that reason. So if they have any sort of orthopedic problem, or if they have foot issues, knee issues, back pain, they might be fearful of getting help out of the notion that their provider might suggest that they need to lose weight as the solution, rather than having their issue to be taken more seriously. Body weight can also derail recovery for those with or who are recovering from an eating disorder. So it's very important as a provider that you make sure that someone feels comfortable having their weight taken. You can also give people the option to do what's called a blind weight, which means that when they step onto a scale at the clinic, they can turn the other way so they don't have to see the number. Because a lot of times the number can actually be very triggering, and you might not know necessarily. People aren't always forthcoming with that. So just giving people the option can be a really kind, thoughtful thing to do. Next slide. It's also important, we're going to talk a little bit about binge eating disorder, but I just want to acknowledge that for people with diabetes, they experience eating disorders at a very high rate. And it's not just binge eating disorder, it can be all types of eating disorders, both for people with type 1 diabetes, type 2 diabetes, and other diabetes, where there's really a focus on nutrition, carb counting, numeric goals. Every time someone with diabetes comes to an office, they often have to have A1C taken, which is another number that they're looking at and being judged by providers. So it can be easy when we're in the medical field not to think about some of those things, but for people who are experiencing this is their reality. So just remembering that can be really, really helpful. Stigma can lead to a very difficult relationship with food, including more frequent stress and binge eating episodes. I'll give a couple of examples. I have had quite a few clients come in and tell stories about providers that they've seen or situations where they've sought healthcare and have been told or suggested to just put down X or just eat less X, whether it's some type of high calorie food, soda, candy bars, you name it. And I've had a lot of people say to me, you know, I'm not eating those things. And so hearing that was really assuming, it was shaming. And in the cases with eating disorders, a lot of times it can cause relapses, it can cause turning to food for comfort or coping. And so those are really kind of the extreme, more aggressive ways. Some subtle things that can come up. You know, when you're a provider, people might be sharing with you their weight journey, or they might be saying, I lost 20 pounds. And instead of saying, I'm immediately saying, you know, that's great, great job. Try to investigate that a little bit further, because sometimes it's not always by healthy means of doing that. Another example, when people are first diagnosed with type 1 diabetes, a lot of times one of the first signs is that they lose weight and it's unexplained. So they're losing weight, but they don't really know why it's happening. So all of a sudden they might be getting compliments from people around them. You know, congratulations, you look great, blah, blah. Well, their body is legitimately starving because the glucose in their bloodstream is not reaching their cells. And so I've had clients tell me that when they went to go see their doctor, they would want to bring up the fact that they've lost a significant amount of weight. And the doctors have said, well, you could lose more because your BMI is still not X, without realizing that they've already lost a substantial amount and that that's not something that they're comfortable with or used to. So as a provider, it's really important to make sure when someone says that they maybe want to talk about weight, you can ask them, you know, what benefits do you see to weight loss? What is it that what weight do you feel comfortable at? What's your usual body weight? What's your weight history? What have you tried before for weight loss, if anything? So really trying to explore that can be very, very helpful. So binge eating disorder specifically is more prevalent in people with diabetes. 20% of people with diabetes have binge eating disorder versus 2 to 3.5% in the general population. And a lot of times the stigma can cause increased use of food as a coping strategy and greater body dissatisfaction. Next slide. So weight inclusive care. So these are some ideas of what you can personally do as a healthcare provider. First, trying to assess any of your own implicit biases, thoughts about weight gain or weight in general. You can ask permission to a client before asking them about their weight or before weighing. Some people carry cards now that say, I would prefer not to be weighed. If you have a client that talks with you about that, you can let them know that that's an option for them if they would like to. You can use language that supports rather than blames, and you can be very mindful of your own nonverbal feedback. That could be, for instance, if someone comes in and they're very anxious because they've put on weight, you want to make sure you don't respond with anxiety back of being like, oh no, that's really significant. You know, you want to try to stay calm. You want to care, obviously, but sometimes when we as providers take on that anxiety, it doesn't help the patient. So just being mindful of some of those like subtleties can be really, really useful. And try to focus on behavior change instead of body size. You know, one question as a dietitian we often ask people is, you know, if we were meeting 3 months from now or 6 months from now, what would you like to be able to accomplish by that time? Well, I want to weigh X, or I want to lose 20 pounds. Okay, that's an outcome, but what are the goals that you want to achieve to be able to get there? What would you feel proud of? Is it making more meals at home? Is it moving more? What types of movement do you enjoy? Those are some examples. Next slide. This is a chart to show you that. So words that work well: activity, movement, what are eating habits. Use with permission, trying to ask people, you know, if we can discuss their weight, or is it, you know, do you feel comfortable talking about BMI? Try to avoid, even in your notes, typing up woman is obese, is a person with obesity. You know, fat, diet, exercise, chubby. So it's, again, that nuance of let's discuss, you know, what is your diet like versus like, here's your diet plan. And to consider for a clinic, private space for measuring body weight, a scale that accommodates larger bodies. That is a really big one. That's important to think about, especially if you're running any type of programs. I teach a lot of weight loss programs, and that's something that people are getting nervous about, is where they're going to be weighed, and the option for patients to have that blind weight taken. Next slide. Again, person first language. So even with diabetes, some people who have had diabetes for a long time prefer to say I'm a diabetic. You never want to argue with someone about what they prefer to call themselves. But when you're referring to someone, trying to say someone who has diabetes, somebody who has obesity or with obesity. Next slide. The role of the registered dietitian. Today is National Registered Dietitian Day for those who celebrate. So dietitians can work inpatient in the hospital. They can also work outpatient, and they work private practices. But our role is really to try to help people to achieve their dreams, so to speak. So whether it's improving their diet, lifestyle, and we can investigate different things. Some dietitians specialize in eating disorders, others do not. So if you're going to refer, you want to make sure you understand the person's background that you're referring to and the type of client that they usually see. But we investigate cravings. We can understand like emotional eating and other disordered eating thoughts and behaviors. One question that's a good one to ask people if you're starting to suspect that there might be eating disorder at play or disordered eating is to say, you know, if you had to draw a pie chart of the percentage of time during the day that you're thinking about food, body, what percentage of time would that be? I've asked that question a bunch of times. I don't think I've ever had someone tell me less than 75% of their day. So if you're suspecting that, go ahead and ask that question so you can get a sense, because they might need a higher level of care. So providers are encouraged to gently refer to mental health professionals who are experienced in eating disorders, so that way they can get the best care possible. Next slide. These are some resources that you can use. So diabetes educator resources are great because they go over all sorts of language things. Project Implicit's free bias tool is good because you can evaluate your own internal bias using different scales and questions. You can obtain different certificates. StopWeightBias.com is great. And then earn education around patient-centered care, person-centered care for individuals who do have a higher weight. So these are just some examples of different resources that are available to you if you wanted to further look into it. Next slide. I'm going to pass it over now to my colleague, Susan Himes. Susan?
Thank you so much, Colleen. I appreciate it. I love that Dr. Anikwe and Colleen, who I've worked with for a number of years, have asked me to jump in and just talk a little bit about my areas of interest. I'm a psychologist who works, I first worked starting in eating disorders at the University of South Florida. And I was really interested in kind of a binge eating disorder. So I studied that quite a bit. And then I transitioned over into working with the weight loss population. And I found a lot of eating disorders in weight loss. So that's how I came to be working at the Weight Center. And I absolutely love it. I'm going to start out by kind of sharing with you a little bit more about weight bias. Colleen and I are doing that component together. And then I'll talk a bit more about binge eating and how that fits into the weight loss treatment planning. But here we have social experiences. So this right now, what I'm doing is talking about how weight bias affects different areas of people's lives and how they experience it. So a lot of kids who are overweight tend to be a lot more rejected than other kids. So one of the interesting things in the research, they show that the kids that everyone wants to play with are kind of quote unquote the kids that seem to be normal or average, and so kids who are different than other kids are the ones that tend to get left out or picked on or, called names or rejected. And so a lot of kids experience that in terms of stigma. And a lot of teenagers report that they have name calling and that they're less likely to date than peers. That's something that we see among teens. Adults report more weight exclusion and mistreatment, especially as you get to the higher part of the BMI scale. So that would mean as your weight goes up and as your weight gets higher and higher, you're more likely to be rejected or more likely to be excluded. And women and men who are overweight are less likely to be married than some of their peers are. And so, if you think about it, if someone is struggling with their weight, then they're more likely to get rejected and have, fewer dating experiences. My husband gets onto me for watching 90 Day Fiance and all these reality TV shows, but I am completely in love with this patient who is the sweetest person in the world named T-Ray, and he struggles with his weight. And related to that, he struggles a lot with rejection and like trying to date women, and he's very socially scared to try to date people, but he's got the best heart and he's the best person and he's wonderful. And so so you can see these kinds of social experiences of weight bias kind of reflected in day-to-day patient life as well as like on TV. So next slide, please. If we think about stigma in healthcare, so a lot of women who struggle with their weight often delay or cancel their appointments. So I had a patient who came to see me, and she told me that she went to her primary care doctor for what she thought was the flu or a virus. And one of the sticking points of her visit with the doctor was that they wanted a weight, pointing out Colleen's earlier mention about weighing, and they kept asking her about BMI. And she said to me, I can't understand why people are asking about my BMI when I'm here for the flu. And and so that was so upsetting to her that she avoided going back to her primary care doctor. And if you think about that, that could have a really negative effect on her health long term if she keeps avoiding going to the primary care doctor. So that's just kind of a clinical example. Even among professionals, even those who treat weight loss, dietitians, medical students, doctors, they report a lot of bias about weight. So is this true for everyone? I'm sure maybe not true for everyone, but I remember whenever I was on my internship that I worked under someone who spoke very negatively about patients at a higher weight. And I remember feeling so bad for them and hoping that she didn't say anything within earshot of them. And because she was a supervisor, I couldn't say anything to her but I witnessed that kind of experience and that internalized bias even within our own profession or even within, our own centers. And then of course, kind of like old stereotypes about weight, kind of associate people with obesity as like stupid or worthless, lazy, those kinds of things. And a lot of my patients even talk about themselves in that way, and you'll see them mention that. Next slide, please. If you think about stigma and mental health, weight bias is kind of divided into this internalized bias versus externalized. So an internalized bias is a negative attribution that you would make about yourself. So like, I'm not smart or I'm not competent. An explicit bias is a negative attribution made to other people, like they're not competent. And if you think about weight, what's happening is that patients at a higher weight are more likely to attribute negative associations and stigma to themselves. So if you think about, like, for example, the African American community has what you would call an in-group bias. So they often think wonderful, positive things about themselves and about other members of their group. But if you think about people who are at a high weight, they often have negative feelings about themselves and other members of their group. And so that is one of the differences to just understand in stigma. And this does contribute to higher rates of anxiety and depression with people. So, obviously, if you're, I had a patient who showed up the other day and said, actually, it wasn't even a patient. I went to the car dealership the other day, and a gentleman pulled up my vehicle, and it was taking him a little bit longer to get out of the car. And he said, "I'm sorry, I'm so fat. I'm so fat and lazy. It's hard for me to get out of here. It's hard for me to get out of this car." And that was just like an example. And if you say things like that to yourself, I actually felt bad for him, because if you say things like that to yourself all the time, you're thinking a lot of negative things about yourself, for sure. Next slide, please. So at this point, we've stopped talking about weight bias, and we're going to move on to talking about binge eating and how binge eating factors into weight. And so many of you might say, hey, Dr. Himes, why are you talking about binge eating disorder? Because that's not the same thing as, weight loss or weight gain. But this is one of the more common eating disorders that you will see if you work with patients at the higher weight end of the spectrum. And so because of that, we just want you to be informed and to be aware of this. So binge eating disorder would be eating a large amount within a few hours, feeling out of control. And usually that would look something like this. If a patient eats a big bag of family-sized chips within a few hours, or eats a whole bag of Oreos within a few hours, and they feel like they literally cannot put the food down, that would be kind of the core piece of what binge eating is. And then in addition to that, some of the other criteria for binge eating, people are often hiding this. So they wait till their kids are in bed and their husband's out of the house, and that's when they do it, whenever they're by themselves. They might feel guilty or terrible or disgusted after eating a bag of chips. They might do this when they're not even really hungry. So let's say they had dinner, but it's 7 p.m. and they're binge eating on a bag of chips. They often feel stuffed, sick, or really extra full whenever they're done. And sometimes people eat rapidly. So keep in mind, you don't have to have all these criteria, but that's kind of the picture of what it looks like whenever you see it. And some of the diagnostic criteria changed over the last 10 years or so, where it used to be twice a week for 6 months to have binge eating disorder. Now it's once a week for 3 months in order to meet criteria for binge eating disorder. And in the past, it was classified under ED and OS, which is basically other specified eating or feeding disorder, but now it's its own disorder diagnostic in the DSM-5. So just to kind of let you know where it's been, where it is now. Next slide, please. So if you think about binge eating, how are you going to see this in your clinics, or how would you see this in the weight loss population? If you go to all of America, about 1.5 to 2% of people report binge eating somewhere in America. But if you go to the weight center or you go to a weight loss clinic, probably anywhere from 9 to 30%, maybe close to a third of people might have binge eating at some point. So again, not everyone is going to gain weight because of binge eating, but some people are. And then 1 to 2% actually meet the criteria for binge eating disorder. So you could be a binge eater and have binge eating, but maybe you don't do it once a week for 3 months. Maybe you do it once every 2 months or something like that. So you don't meet criteria for binge eating disorder. And then when you look at the bariatric population, so you look at people who are going for bariatric surgery, you see more like 3 to 16% of people meeting criteria for that disorder. And some of the things that are unique about this disorder are that the average age of onset is 25. So when you're looking at things like anorexia or bulimia, kind of the more traditional eating disorders, you see that happening at younger ages. So those are more like 18, 19, 20. This is a little bit older. And then this is kind of more evenly distributed with men and women. So like about 4% of men, about 5% of women have binge eating disorder. So basically, like if you think about anorexia, that disproportionately affects women. That's much more women than men. But binge eating disorder could affect both about equally. So just to keep that in mind. Next slide, please.
Dr. Himes, sorry to interrupt. This is
Oh, sure.
wonderful. This is wonderful. If you
Sure.
could aim to wrap up in the next minute or so, that would be excellent. Thank you.
I will do that. I will aim for that. Thank you.
Thank you.
Thank you for the prompt. I appreciate it. This next slide just shows the strong relationship between binge eating and depression and how they're strongly correlated with each other. So when you have more depression, you often have more binge eating. Next slide, please. So why do we even want to study this? When people binge eat, they are more often having trouble losing weight. They get frustrated and they drop out of weight loss clinics. They might have dumping syndrome, which is when people could say binge, like they have a mini binge after their surgery and they end up having bad diarrhea or vomiting. And it can be associated with weight regain and people not losing and getting stuck. Next slide, please. So some of the treatments for binge eating include cognitive behavioral therapy, Prozac, which is basically an antidepressant. We've got arfentermine, topiramate, or Casimia, again, can help reduce binge eating. Vyvanse. So these are kind of more cognitive behavioral therapy, and then these medicines help binge eating. And if you look at the last two, like the Vyvanse and the GLP-1s, like the Saxendas and the Ozempics, those two are probably have the strongest data behind them of reducing binge eating by about 4 binge episodes a week. So there's like a decrease more with those than probably with the other treatments. Next slide, please. So if you think about treatment of binge eating, one type of treatment is to use the dietary pathway. So if someone goes to a behavioral weight loss program and is trying to eat breakfast, lunch, and dinner and trying to eat, roughly healthy meals, that really can help people actually decrease binge eating, that one treatment in and of itself. So my typical patient like this would be a nurse who works all day, like a 12-hour shift, and doesn't stop to eat because she's on the go and she doesn't stop to eat anything. And then she comes home at night and has a binge on like a large pizza all at once because she's ravenous. So that would be a typical patient I might see in this pathway. Next slide, please. So, sorry, from the prior slide, about a third of patients, so about 36%, will be in remission from binge eating if they go on that healthy dietary pathway of just trying to eat regular meals and improve their healthy eating. Thank you so much. Next slide, please. 2 of the mood treatment pathways are CBT and DBT. And one of them kind of challenges a lot of the negative thinking that is associated with depressive symptoms. And the other tries to help people regulate their mood better. The DBT does. And you're looking at probably 80 to 90% remission rates with these treatments for binge eating disorder. And then IPT is kind of an interpersonal therapy. So it's for people who are like, I fought with my spouse and I had binge eating, so it's like trying to help resolve interpersonal conflicts that people might have. And you see more like a 73% remission of binge eating with that treatment. Next slide, please. So if you think about the addiction model, this is not a formal model, but a lot of my patients report that they feel addicted to food. And so one of the models I think about is kind of binge eating being an addiction for some of my patients. They feel that way. And so you're trying to identify the triggers. You're thinking about, like, for example, cognitions. It's me time. This is my chance. I've had a bad day. I need something to eat. Or another example for treatment might be, going to the dog park at 3 o'clock whenever you're likely to binge at home, but you're trying to deliberately plan and do another activity during that time window. Those are just kind of examples. Next slide, please. And in summary, if binge eating disorder is clinically severe, it can lead to poor weight loss outcomes, and people might end up dropping out of treatment. Both the CBT and the DBT are effective interventions, and those are treatments. I use all of those treatments at my clinic. So I use CBT and DBT in a BEST program that I run. And then we also try to encourage people to use those behavioral treatments of eating regular meals and eating more nutritionally sound. So we're using like 3 or 4 different combinations of treatment in the psychological treatments for binge eating. Next slide, please. And then here are my references, and I will conclude my slides. Sorry if I ran just a little bit over. Thank you. Thank you, Regis.
Thank you very much. So now we want to invite Donna Smith-Williams. And Donna is going to share a little bit about the patient's experience, if Donna is around.
I am here. I'm going to start my video.
Thank you.
Okay. At least I'm trying to start my video. Okay, I'm there. Hello, everyone. My name is Donna Smith-Williams. I am a patient of Dr. Anikwe's. I've been a member at the Mass General Weight Center since about 2003. I didn't have gastric bypass until 2008, October 27th, 2008. I tried several different medications before choosing to have gastric bypass. I did several weight loss programs, curves, Weight Watchers, you name it. I did metformin, which didn't work for me as well. I tried everything, you name it. It wasn't easy the decision to have gastric bypass was not easy for me, but I'm happy that I did it. Again, I had it on the 27th of October, 2008. It's been like 15 or so years now. I keep my weight off. I was like 330 the day of surgery. I am currently 170 pounds now. I am using Wegovy. I did gain back a few pounds about 2 years or so ago. So I am currently taking Wegovy. Wegovy's working for me. I did try, Dr. Anikwe and I did try a few other medications before we went with Wegovy. I did the Tempramate and the phentermine, the phentermine brought up my blood pressure, and the Tempramate just didn't work very well for me. So Wegovy is working very well for me. I feel good. I have no regrets. I can say the first 50 pounds I lost, I went from not having a menstrual period for 20 years to becoming fertile myrtle. I had my first child at 43, thanks to losing weight. So I'm 52 with a 9-year-old, and everyone thinks I'm her grandmother. So that's one of the happiest things that had to happen to me. Like, I've actually went through IVF when I was overweight, knowing that I had polycystic ovary syndrome and it probably would not work for me. I still tried it. And I knew that losing weight would be, the best thing I could do, having polycystic ovary syndrome. And it really was the best gift I could give myself. I feel wonderful. Again, I have no regrets. My daughter she has Down syndrome and she's a little overweight. She's doing well. She's a patient at Mass General Pediatric Weight Center as well. I'm getting on top of her weight now. She's actually taking metformin as well, which is doing very good for her at the moment. So again, I'm an advocate, for weight loss. I'm an advocate for Mass General Weight Center. I'm still a patient. I still, I'll always be a patient. I feel like I'll always need help with weight management, and I'm here to stay. And so if you have any questions for me, let me know. And I do exercise, everyone. I have flat feet. So, at 330 pounds, I couldn't even walk across the street without my feet killing me. So I'll tell you, it feels really great to be able to walk now and not having my feet hurt me, not having my back hurt me. I do a lot of walking, and it was just one of the best gifts I could have ever given myself. I haven't had any side effects, anything negative. I mean, of course, I've experienced dumping syndrome, but once you experience that, what not to eat and what not to eat. So it's been very successful for me. So I'm happy. I wouldn't change anything about it.
Thank you so much, Donna.
Thank you.
Somebody in the chat shared, thank you for sharing your story. So
thank you. for having me.
Yeah, definitely. All right, so we can officially open it up for Q&A. So I encourage you to submit your questions directly to the chat. You can also do a direct message to Tyler Feaster if you prefer that method. And then during the last 10 minutes, so about 8:15 to 8:25, we'll open it up to anyone who wants to raise their hand and come on and ask the question. So feel free to submit your questions now in the chat.
Oh, we're waiting. Just want to say thank you, Donna. Sounds like we paid you to come on here and then say all that great stuff, but we did not. So thank you for sharing with us.
Oh, you're welcome. No problem. I'm glad to always share my story. You know, because it's been a great experience for me, and I wouldn't change anything about it. So thank you for asking me to share my story. I appreciate that.
We appreciate you, and we're not letting you go. So if you thought about leaving,
I'm not going anywhere.
Yeah, I do have a comment or two. As the as someone also who has experienced the same thing as Donna, and I think I've done the whole pathway as well. And I think what's important that you've mentioned too is staying with the program that you're working with, and whether it's Newton Wellesley or whether it's Tufts or whether it's MGH, be sure that the program has the continued program and the commitment to you as an individual. And it is life-changing without a doubt. And I think what's amazing, as I've listened to this whole presentation, I go back to when I was a nurse a student in 1968. And that's when they were giving out like sort of like amphetamine type drugs to control your appetite. And you'd run around like an idiot, getting everything done. You were an amazing nurse, but it wasn't the answer. And boy, have we come a long way. We really have. So I'll let others ask questions. Otherwise, I do have questions.
All right, I know I have a whole long list of questions, but I'll save those. I don't want to just take up all the time. Okay, I do have a question that came in. Looks like this one is for Dr. Inekwa. Have you seen any issues with menstrual cycle changes with Wegovy?
hi, thanks for the question. So I will just say that the predominant demographic that we see at the weight center is the peri or postmenopausal woman, mostly because I would say that is when many people start to experience weight gain in the course of their lifespan. So when you talk about introducing medications or having treatment plans in that time frame of when menopause might be occurring or has started, but you're not sure if it's actually in a full-blown situation, that can coincide. Generally, though, what we see actually just coincides with what Donna just shared, which is that when a person loses a significant amount of weight, that can improve fertility, whether it's through bariatric surgery or medical pharmacotherapy approaches or behavioral lifestyle approaches. So that can affect menstrual cycles. And then I'll actually just jump to another question that's further down on the chat with the PCOS component, which is that PCOS can also be related to hormonal changes that are like kind of encompassed by the obesity diagnosis. So it can be associated with excess weight, difficulty with menstrual cycles or irregular menses and such. So treating the obesity can then kind of in concert help reduce the severity of PCOS, which can improve fertility. And then you start to see more regular menstrual cycles and increased fertility. So I kind of answered both questions. Sorry if that was not what you wanted.
No, thank you. That's wonderful. All right, thank you for that, Donna. Just so you know, more positive feedback is coming through in the chat too. So thank you again for sharing. This will be for anyone who feels like responding. Any resources for children experiencing obesity, lifestyle changes, working with a dietitian, medication? What's the approach with pharmacotherapy and pediatrics? So open that up to anyone.
Dr. Nikwe, are you okay if I respond since I'm on the PD team?
Go ahead, please do.
Okay, great. So I work with the pediatric group at Mass General who is seeing child clients. What I would say is that usually most patients start out with working with their dietitian with the schools, or a dietitian in their area. If their child is struggling, some people have gone like with family dietitians. And then if they're continuing to struggle, some people have graduated to going to the OWL program, which is kind of more of a very intensive behavioral program for kids with weight struggles. So that would involve seeing a dietitian weekly, and a kind of more intense treatment is what is more helpful behaviorally. At Mass General, they don't have the bandwidth to implement that type of program, so that's offered at a different hospital. But we see kids with, and we provide medications and or surgeries to kids who are struggling very much and have tried other treatments first, especially if it's affecting their health. But there's a lot of rules around that in terms of what age someone would have to be to take certain medicines or would be approved for surgery. And sometimes it's a case by case basis too. So, but I would say that a lot of our teens, probably like 14, 15, 16, we have a strong pediatric surgery adolescent program, I would say. And we do see a number of kids before that, especially kids with special needs. We see that quite a bit as well. I think, Donna, you were mentioning like your daughter with Down syndrome. So I see a lot of kids with like Down syndrome, or kids with autism that are more represented in my clinic too.
Yeah, I'm happy that my daughter's a part of this program. This is the only pediatric weight center that I know of. So I was really happy that when they opened at Mass General, I was able to get her in, because with her having Down syndrome, most of them do have weight issues, and she is starting to have weight issues, but the metformin is working for her. So I'm trying to prevent her from having gastric bypass like me. So that's what the goal is.
I was just going to add too, so the dietitian standpoint, the youngest children I would treat would be 5 years old, and then up. That's what I saw in clinic. I'm doing young adults now, but in the past, yeah, so there definitely are dietitians out there that can see children even from a young age. Usually they're working more with the parents than the kids, but it was fun having the kids come in and color and whatnot.
Thank you, everyone, for responding to that. Deb, I see your post. Thank you for sharing that. I don't see a specific question. If you want me to ask a specific question, I'm happy to, but thank you. I want you to know I saw it. I saw your post. A follow-up related to pediatrics. At what age is bariatric surgery now recommended for pediatric patients who have failed other non-surgical treatment? And that's open to anyone who wants to respond.
I would say in our pediatric surgery program, we probably see teens who have failed other treatments, probably most commonly between like 14 and 18, I would say, in the adolescent program. We do see some kids who are like 19, 20 that are in the pediatric program as well, because operationally, some of them operate more like kids than adults. But that's probably the target age. I would say most of them are, I would say.
Do you find that weight loss surgery has been successful with the young, like with the teenagers? Because, being a teenager, you like burgers, you like fries, you're hanging around your friends and they're eating stuff like that. Has it been successful for them?
It has. So, so both the research and my clinical experience is that a lot of kids are doing well with their bariatric surgery. And you might be surprised, because kids do have a harder time with adherence because they're not mature and they're surrounded by their friends with, like you said, the burgers and fries. But I will say that one of the things that we do heavily is a lot of preparatory work before and after the surgery to really screen for and work with people to make sure that they're implementing behavioral changes. And while we can't be there forever after their surgeries, the people who end up regaining or struggling with regain tend to gravitate back to old patterns that they had before. But to be in our program, they have to demonstrate a certain amount of adherence and being able to do the skills for surgery, or else they wouldn't be approved, for sure.
Thank you.
Thank you for that. Question about gastric banding. Is this procedure still being performed? Has it fallen out of favor? And that is open to anyone who wants to respond.
Yeah, I can take this one. That was one of the last ones, so I went quickly over it. Lap bands are rarely performed now in the United States because it's only the restrictive aspect and none of the metabolic effect. So in numbers wise of all of the bariatric and metabolic surgeries, it's actually performed less than 1% of the time. I think the exact number is like 0.9%. So we're really getting away from it because there's a lot more risks than benefits, right? Everything in medicine is a risk-benefit balance. And we have so many better options with better benefits and less risks. So yeah, rarely performed now in the US.
Thank you for that. Oh, is it time for me to ask one of my questions? Maybe. So many. I'm open to anybody responding to it. I've seen some information about muscle loss with semaglutide tirzepatide. Is that something that can be prevented? So for someone who's starting that medication, if they lose like a disproportionate amount of muscle instead of body fat, is that something that can be prevented? Any thoughts on that?
Not really. I can jump in. Happy to hear
Yeah.
other people's perspectives as well. But when you lose weight, automatically you're going to lose some muscle. And I guess what the question, if I could tweak it, would be is, can you minimize the amount of muscle that's lost when you're losing weight? Which, yes, you can. Which the things that we typically recommend would be making sure you're getting adequate protein. So obviously our dietitian colleagues are helpful with getting people that information about recommended protein intake. And then also doing strength training to help, optimize the strength and the lean muscle that you have and trying to maximize that. So yeah, if you look at kind of diagrams of expected weight loss and expected muscle loss in relation to weight loss, most diets, you're going to lose at least like 20% of your muscle mass. Like 20% of the weight that you're losing is muscle or lean mass. But you can mitigate that with, protein and strength training.
Excellent, thank you. Penny, did you want to ask one of your questions?
Hold on, I'll find it. I think I came up with 4, but I'll find the most important one. Oh, I know, because I've had this happen to me. And this can go to probably Colleen or Susan. When an obese person makes a really negative comment about themselves, what is the best way? And this is just like a friend or, like you said, someone getting out of the car, and they make this negative comment. What's the best thing how to respond to that? Or do you respond at all?
Colleen, I'll let you go first and then I'll pick up.
Okay, great. Penny, when you asked that question, I thought immediately of this. I'm doing an eating disorder prevention research program right now. It's called the Body Project, but they practice it around the globe. And one of the activities is to actually have people practice. So the moderator will say something self-deprecating and the group members actually have to practice saying one-liners back to that person. And so that sort of evidence has been shown to be really effective, both for the people who are listening and I think the people who are practicing those things of saying, when someone says something self-deprecating, just kind of asking, a question back of, oh, that's a really interesting point. Why do you think that might be the case? Or I don't know, Susan, if you have like more concrete examples, but.
No, I think that's great, Colleen, because when this gentleman at the car dealership said that yesterday, I was, as most of the time in my life, I don't have the words, right?
Okay.
When I always think of what I should have said like 2 hours later, and why didn't I say what I was supposed to say? So unfortunately, I didn't respond back in that moment because I wasn't prepared, which speaks to what you were saying, Colleen, that if you practice what you're going to say in those settings, I think you can get better at it. But I can definitely tell you if I had a patient sitting before me who said that, which has happened to me many times, sometimes I try to gently challenge them. And so like if someone says, I'm so lazy, I didn't do what I was supposed to do, I ate terrible, or whatever. And, and I'll say something to them like, I don't know if you were lazy. It sounds to me like you were tired last night and you didn't have a chance to prepare. What can you do now? And so I'm kind of gently trying to challenge their negative view of themselves and view themselves in a more proactive way where instead of just berating themselves and beating themselves up, they can feel more in charge of doing things and taking actions to feel better. So
I think the most important thing you're saying is that you do need to practice responding, and that you need to, sort of reframe whatever it is they're saying in a more positive way. So, can I do one more question, Ryan?
Yes, I
Okay.
grant you permission. Yes.
Thank you. Of course, I'm coming from this. When you talked, that was the first time I've heard about the pathways, the two pathways in the brain, and I forget who spoke about that. But do we all have those two pathways, and does one dominate over another, or do they act the same?
Yeah, the anorexigenic or exogenic pathways. Yeah, that was like my slide that I borrowed from Dr. Stanford. But yeah, everybody has both those pathways. And it's basically how our body, we didn't really get a chance to go into like the specifics and all the details of appetite regulation because that could be a lecture by itself. But basically, there's multiple hormones that act on different levels. Talking about from the brain, the brain has receptors. The hormones are coming from different locations in the GI tract and even from our fat cells themselves, from the pancreas, the other organs. So there's a lot going in, a lot coming out when you talk about like the gut brain axis and the appetite regulation axis. And then separately from that, there's a whole other system for fat storage. So what allows your body to store fat when needed and then release fat from storage when needed. If you kind of look at the historical perspective and why, the thinking behind why obesity is such a large problem and such a growing problem is that historically and even prehistorically, we never needed to like store fat, or we wanted to store fat because we always were living in a period of scarcity. So any excess calories that you had in your environment, you wanted your body to be able to hold on to that so that there were periods when you didn't have access to food and you were able to live from your fat stores. Now, obviously, it's a completely different situation where we have food everywhere. Everywhere you turn, there's access to food, and not just any food, but really highly processed, highly palatable, high sugar, high additives, really food that's not even what we define as nutritional food. It's just like calories and, and sugar and fat. So yeah, this balance, we're kind of living in an environment that we weren't designed to live in. And that's why our bodies often struggle to maintain the right amount of body fat and the healthy amount of body fat.
Okay, Professor Andrews, I'll turn it back to you instead of monopolizing.
Thank you. Appreciate it. So if anyone else has questions, feel free to post. You can raise your hand. I would love to hear from anyone about, and this is a big question, how we can improve our food environment. Anything, big, small, advertising related, taxation, whatever is on your mind in relation to the food environment, if anything at all. I have to bring up something related to food.
So I don't know that I have a lot of policy ideas, but I know of a resource that would be great, which is I think of Kelly Brunell's work at the Yale Rudd Center, where they try to advocate for a lot of policies, and he wrote a book about the toxic obesogenic environment and kind of all of these kinds of issues, like from soda taxes to, he had all kinds of very specific policy ideas. I got to hear him speak about 10 years ago. But if you have, I don't know if that's an area of your interest or an area of research that you're doing, if you're thinking of certain policy proposals, but I always think of Kelly Brunell when I think about that issue.
Thank you. Yeah, I love his stuff. He has some good stuff on weight bias and stigma too. Yeah, thank you. Anyone else thoughts about the food environment? Big, small, anything, just like nudging people in a direction of maybe a healthier diet
Yeah, I
type of a
think
thing.
it's a really loaded question you asked. I want to hear the other panelists as well, but because my background is preventive medicine and public health, so I definitely think about it a lot. Like, what could we do differently to help people with their environment and creating an environment that's going to help people to choose the right choices and the healthy choices. Understanding that people also want a sense of agency and free will, and they don't, nobody wants to be told what to do. Even like our children, our toddlers, our adolescents, nobody wants to be feeling like they're forced into anything. But if you want to like really have a society that's functioning to the best of its ability, we have to design that environment that allows people to have the healthier choices be more easily accessible. So that ranges from a lot of different ways. And there's been a lot of proposals in different parts of the country. Some have prospered, some have failed. In terms of like controlling fat and sugar and looking at warning labels and nutrition labels on signage and fast food restaurants, for example. The built environment is a big concept, like designing cities and outdoor spaces for people to be accessible, have access to safe outdoor activity space. When I think about just in-home ideas, like when I just thinking about my son, for example, I try to have like healthy foods in sight and visible and keep up the more processed things away hidden. So when you want a snack, what's available is something that you want to be eating and that's more healthy for you, as opposed to going to look. You might know what's in the drawer, but like if it's not right in front of your face, you might not be as easily reaching for it. So those are just things that come to my mind. I'd love to hear what others' thoughts are as well.
Yeah, Kate, I would say, oh, Colleen, okay if I go?
Oh, no, go ahead, Corinne.
Okay. Like there's food deserts, right? Like there are people living in neighborhoods where a Whole Foods isn't for miles or miles, or Whole Foods is like the only grocery store they have and they can't afford that. Or the fact that, our sizes at fast foods have only increased over time. Like you can get like a 42-ounce soda, which was not available like 10, 20 years ago. I'm not sure the exact timing. So I think part of it is advertising. I think, I don't have policy ideas, but I usually say like follow the money. And I think it probably have to be on multiple levels, right? Like the food industry, access the food deserts, historically the redlining districts, the socioeconomic status. Like I think there's so many factors that probably would need to all be addressed to get to the point that we would all in a perfect world would want. So there's probably, I don't think there's any one answer, and I think we all probably know that. So I think probably like having talks like this and educating the public. I think we do not a great job of educating everyone about nutrition in school, right? Like I don't know how to do my taxes. I know the wheel of nutrition, but that's about it. Like what is fiber? What is, good fats versus bad fats? So I think, if I had to pick some low-hanging fruit, it would be providing more education to our like middle school, high school, those sort of age groups, and of course adults. But I think it would have to be a good like big public health sort of movement.
Agreed. And even Colleen, I wanted to hear you too, but even in medical schools, it's often an elective part of the curriculum, not a required part. So all the training that I have is because I sought it out for the most part. Otherwise, you just get like one slide on one talk and you're supposed to be able to counsel patients based off of that, which is obviously not, doable.
Yeah, I think these are such great points. And I think a couple of people in the chat wrote like food deserts, or like what's the role of culture on food choices. And I think our culture in this country is tough because I think people have extremely high levels of cortisol, because all day long I'm monitoring people's blood sugars now. We're in these charts that we're in continuous glucose monitors. I see people's blood sugars go up when they watch a scary movie. I see people's blood sugars go up when they see a fox jump out at them. So it's so interesting to see how much the stress of our very stressful environment that we live in and how that's affecting our body. And I think that because our jobs are so sedentary and because our food environment has to be so quick, so convenient, and so cheap, because a lot of people, especially now, are dealing with financial struggles, I think that sort of culture and environment is setting people up so that they are also not a lot of people get great sleep. Susan Himes, I'm sure you experience this too. Your clients will tell you, I'm struggling with sleep, and it becomes a chicken or the egg scenario. It's like these things are all contributing to more weight gain. It's making it tougher to do these things and so on and so forth. So it's like, how can we turn the wheel back? And so we can really only focus on the things that we can do to turn the wheel back, like the bigger things of structurally in our very stressful environment. Not sure. I have gone to seminars on how to reduce stress and how to lower cortisol levels. There's all sorts of tips and tricks. Massage will lower it for 6 weeks, one massage, right? So learning some of these things I think can be helpful, like on a one-on-one basis with clients.
Thank you, Colleen. Happy Registered Dietitian Day, by the way. All right, so we need to wrap up. The evaluation link should be posted in the chat at any time. Make sure to complete that if you want your CEUs. And thank you very much for your time and attention this evening. Special thank you to Harvard Pilgrim Health for their sponsorship and to our panelists. Make sure you grab that link. It'll be posted for another 15 minutes or so. Once you have it, thank you very much. Have a nice evening.